nice talk about robotic assisted radical prostatectomy, and I'm insisted that until now it's robotic assisted. I hope it will stay like this, not be in the future totally robotic and out of the game. Everything has been started more than 100 years ago like this. Every urologist has to know and do everything by open surgery. But a few decades ago, New York magazine came out with this title, looking for surgery without scar, looking for minimally invasive surgery. Was it the dream of humanity? In reality, our dream is to move on from open surgery to endo surgery, and this is the era we are talking about, and we are working in right now to extracorporeal treatment. And urologists are proud to be the first who have done or reached to the top of this dream. Working on stones, we are managing most of our stones right now extracorporeal, without surgery, without endo surgery. In the future, this may be the way to go with every disease. Even with some brain tumors right now, they are treating it extracorporeal, without endoscopy and without open surgery. Laparoscopic surgery, I think, this is the way that our way for robotic assisted surgery has been started 15 years in the last century, 15 years ago in the last century, and showed a lot of advancement in the technique and technology. But is it really minimally invasive? Is it ideal for its patient and for the doctor? Yes, it offers the patient a lot of things like less pain, shorter hospital stay, rapid return to work, etc. But still, the doctors has to complain, as Dr. Ali said, after many years of working as a laparoscopist, he developed something in his spine and he has to rest because of these drawbacks that are associated with the standard laparoscopic surgery. That's why we have shifted, according to the new technology, to get help from the robot, to get rid of these drawbacks. As a part of the new technology, robotic assisted surgery is considered one of the examples of this technological advancement in this era, and with which there are a lot of improvement right now in the machines, and waiting for more improvement for easy and accessible techniques. In reality, Da Vinci has been developed to target the heart, to make some cardiac surgery that have been difficult to be done with a human being. But what happened? It hits the prostate, as Dr. Ali said. We are proud, and we should be proud to be urologists, because we taught the technology and we make it work better for our patients, as we will see in these numbers between 2006 and recent days. We will find a lot of cases, a lot of procedures done by urologists, even more than any other specialty. For example, in 2006, 70,000 robotic assisted surgical procedures were performed all over the world, reported. Most of them, almost half of them, were in the form of radical prostatectomy for localized tumor. This is another example of the numbers that will show that how much urologists are working with the robot. In USA, in 2001, less than 1% of the cases of radical prostatectomy were done robotic assisted. In 2006, almost half of the cases started to be done this way. And 2009, close to 100,000 cases of localized tumors are taken out by robot-assisted radical prostatectomy technique. This is a list with showing most of the procedures that can be done by Da Vinci or robot assisted, beside other procedures. And this is another list by the most common procedures that are published in the literature: prostatectomy, cystectomy, nephrectomy with a radical or partial, pelvic lymph node dissection, and some reconstructive procedures, including the sacrocolpopexy or pyeloplasty. As such, the European Association of Urology started to put some rules. Where are we going in the future? We have to have some guidelines for using robot-assisted surgery in the future. I'm going to talk on each procedure in a few minutes or few slides. What did they say in their panel? As regards robot-assisted radical nephrectomy, it has been first described in 2000, and they showed that the main limitation was there is technical effort associated with the build-up, not the procedure itself, to prepare the patient, to put the trocars, to make everything ready to go. This takes some time. And of course, as Dr. Ali mentioned, it's costly and still costly for economic reasons or for privacy reasons. Just one company all over the planet is allowed to make Da Vinci up till now. Maybe in the future, this issue will be challenging. And of course, there was no significant improvement in the oncological outcome when we compare the procedure with the standard laparoscopic or when we use less technique. As regards the complication, it's still almost as reported by the standard laparoscopy. Comparative data between robotic assisted or standard laparoscopy are still limited. Longer term follow-up are still waited. As such, they consider robotic assisted radical nephrectomy may be considered a technical over-treatment for today, and its use should therefore be weighted against the standard laparoscopic radical nephrectomy, depending on the individual case and even on the individual center. Moving on, talking about the partial nephrectomy, the technique has been shown in 2004, and the outcome as well as the complication were comparable to the standard laparoscopic technique. However, with larger tumors, more than 4 centimeters, they found in some literature that the complication rate were still higher using the robotic assisted technique. And the conclusion was robotic assisted partial nephrectomy is a safe and viable alternative. As such, we will find some of the numbers are missing here because of the technique is recent, there is no much literature, there is no comparative study to get a good level of evidence or grade of recommendation when we talk about partial or radical nephrectomy. On the other hand, we will come to the big piece of work right now where they are using Da Vinci almost all over Europe and everywhere in the United States for radical prostatectomy. Following the introduction of the technique, the procedure has gained widespread acceptance, as I said, in US and of course all over Europe. However, due to the relatively recent introduction of the approach, again, few studies, comparative studies, few prospective studies, little data, and we are waiting for these data to come out. However, from the data, the available data, we can find that the oncological outcome is almost the same when we compare robotic assisted radical prostatectomy to the standard open or the standard laparoscopic technique, and comparative study between robotic assisted to open or the standard laparoscopy showing reported equivalent or even lower positive surgical margins. This is because you see better, you see with magnification And even the point anastomosis, we can do it better with report because it will control the better vision. I think report took us to the little narrow spaces between the urethra and the bladder neck, make it almost in your hand. And this is the trick that makes continence as well as potency are doing better after robotic-assisted radical prostatectomy when they compare with the open or the standard laparoscopic techniques. However, this data came from little number of literations. Here, we can find that the level of evidence as well as the great recommendation are doing better when we talk about radical prostatectomy. And as I said, all depends on the number of cases, number of literatures, data available, and so on. Other technique, robotic-assisted pelvic lymph node dissection. What do we need from pelvic lymph node dissection? Actually, we need the largest number of lymph nodes and the higher sensitivity to detect positive lymph nodes in each case, because this will change your decision. When they compare robot-assisted pelvic lymph node with the open technique, of course, open technique will win at this time. And again, the available data in other studies were limited, and the reasons why open came better in these studies because the comparison of the well-established, which is the open technique, to a newly approach technique, I think this is not fair, as well as some of the data were incorporating the learning curve in some studies. As regards the radical cystectomy, it's done right now in many centers, few centers in the United States, and fewer in Europe, and even it has been done in Mansoura Center, as few cases have been done there. Today, there are few studies comparing the safety and complication of robotic-assisted radical cystectomy to the standard open technique. However, the data shows that the perioperative and long-term safety of both techniques with a robotic-assisted open are almost the same, complications are almost the same, this figure, including even minor complication, and they came with the conclusion that robotic-assisted radical cystectomy result in less blood loss, less morbidity, and overall, it causes earlier initiation of any adjuvant therapy after the radical cystoprostatectomy. As regards the oncological outcome, it's equal to the open technique, and the long-term oncological efficacy of this relatively new technique is waited to be determined. In this regard, we will find also that the technique was accepted from the panel in the European Association of Urology, but still needs more studies to turn this number to better numbers in the near future. Now, we will move on to other techniques, reconstructive procedures that can be done by robotic assisted. Talking about laparoscopic pyeloplasty, the first case that has been reported to be done robotic assisted, it was in 1999, and currently you will find this title in most of the literature dealing with children who underwent robotic assisted pyeloplasty or uretero-pelvic junction extractions. However, the data available in adults shows that the outcomes are comparable, but the key is the suture type. The type you use just for re-anastomosis between the ureter and the pelvis, it's significantly less when you are using robotic assist. And this can be understood because you have better control on the needle when you use the robot. The other reconstructive techniques that we can find some data about is the sacrocolpopexy. Yes, there were few studies or few literature about sacrocolpopexy, but it was not astonishing for us that using the robot The results was approaching almost 100% success rate because again, with the robot, you have better control to put the suture at the site you would like to have, and you will have better control on the needle. As such, we'll find better numbers here when we will look at the European European Urological Association guidelines, where they recommend the procedure to be done by robotic-assisted technique. The panel has discussed, after putting these guidelines in 2013, they have discussed the issue of cost. And what they have found, resources limitation made it impossible for the guideline panel to perform a comparative cost analysis between the open, laparoscopic, standard I mean, versus robot-assisted surgery. And they suggested that robot surgery is more expensive than open and laparoscopic surgery in approximately 75% of cases, with any cost-saving benefits of robot surgery attributed to variation in hospitalization cost. Even with having shorter hospital stay, still robotic surgery costs a lot. In addition, the only robotic system assessed in the clinical study and currently available is the Vinci, as I said. When we will have other sources for robots, cost may go down. And the conclusion of European Association of Urology guidelines on robots, they concluded that robot-assisted urologic surgery is an emerging and safe technology for most of urological procedures. Further documentation, including long-term oncological as well as functional outcomes, is required and necessary before definite conclusion can be drawn regarding the superiority or not of robotic-assisted procedure when we come to compare with the conventional laparoscopic and open approach. In the future, we believe that all complex laparoscopic procedures will be done easier for the surgeon and better for the patient using the robot. All laparoscopic surgery will be done by robot, as Dr. Ali just said. Further improvement in the technology will make it easier if we have smaller robot, flexible instruments, and of course, telesurgery will make it easier. One surgeon can work for most of the world's surgeons. Dr. Ali said, we are still the master. And it's real right now. But I'm afraid in the future, the picture will be like this, and everything will be done by the robot. Thank you.